Well, good afternoon. I'm Dennis Vonderfecht, president of Mountain States Health Alliance. We have a small but select group that are really diehards on leadership development here, so I know we have the benefit of that. And you have the benefit of, as the saying goes, the best is saved for last. So I'm going to kick this off, and Pat's really going to do a lot of the discussion. But first of all, our location, we're located in Northeast Tennessee and Southwest Virginia. We have a 29-county service area that makes up our service area for Mountain States Health Alliance. It's known as the Southern Appalachia region. And I could talk about what it is, but I think visually I want to show you what it is through some slides of people and places of Northeast Tennessee and Southwest Virginia. As you can see, it's beautiful country. As a fellow CEO located in Ohio says, it's la-la land, and it may be from that standpoint in terms of beauty, but definitely in terms of demographics, it's not. If you look at our demographics in our area, it is very much Appalachia. It's a very slow-growing population. It's an aging population. In terms of the educational level, it's lower than the states of Tennessee and Virginia and the nation as a whole. Same thing for the income distribution. All of that relates to the fact that we have a higher rate of prevalence of many of the disease categories that we have to deal with as healthcare professionals. A little bit about Mountain States Health Alliance. We are the largest health system in that 29-county service area, making up parts of 4 different states: Northeast Tennessee, Southwest Virginia, Western North Carolina, and Southeast Kentucky. We have 14 hospitals in our system. I'll talk a little bit more about those here shortly. And our workforce consists of 9,000 team members, about 1,220 physicians, 3,500 volunteers, and 3,500 students. These are our 14 hospitals. We have 8 of those, or actually 9 now, of those in Northeast Tennessee and then 5 in Southwest Virginia. We just added the last hospital, Unicoi County Memorial Hospital, the 1st of November. We have a rather diverse group of hospitals. We have one tertiary hospital. It's a safety net hospital for the state of Tennessee, level 1 trauma center, level 3 neonatal nursery, all those high-level tertiary level services. We also have a number of community hospitals, and that tapers down all the way down to 2 federally designated critical access hospitals, one of those with 2 licensed beds, so you can imagine that's pretty small. We also have a number of specialty hospitals, having a children's hospital, a psychiatric hospital, and then also a rehabilitation hospital. Besides hospitals, though, and becoming increasingly more important, is that whole continuum of care that we have within Mountain States Health Alliance that we've developed over the last number of years. That includes 400 employed physicians, a number of outpatient ambulatory centers, and then most recently our own health plan, the only Tennessee hospital or health system that has its own health plan. Again, this is our service area of Northeast Tennessee, Southwest Virginia. I have to look at the colors on here because it didn't show up right here. The orange represents Southeast Kentucky, and then Western North Carolina is in the blue, and then the location of all of our hospitals. Just a little bit about our business model. We have used over the last 12 years or so the Baldrige National Quality Award criteria as the business model for Mountain States Health Alliance. Along our quality journey, we received quite a bit of recognition using that model. In Tennessee, there's a very active Baldrige organization called the Tennessee Center for Performance Excellence. We've received the highest level recognition in Tennessee for 3 times now, 2005, 9, and 13, having to sit out those years in between. We're the only organization in Tennessee to have ever been recognized 3 times at the highest level with respect to the Baldrige criteria. Last year, 2012, we decided since we have 5 hospitals in Virginia, we need to apply with the Virginia organization around Baldrige, which is the Virginia U.S. Senate and Productivity Award. Right out of the chute, we received the highest level recognition in Virginia, the first time they'd given that in 3 years. It's called the Medallion Award. Last year also received recognition from the National Quality Forum, being selected as their 2012 National Quality Healthcare Award recipient. We're very proud of that. We're the only hospital or health system in Tennessee to have ever received that, and only the second one in Virginia to have received it. Also, as far as the Baldrige National Quality Award itself, the last 2 years we've received site visits, one of just a few, very small handful of healthcare organizations to get those site visits. Still haven't gotten the award, but we're very, very pleased to be this far on our journey and to get those feedback reports, because it really does help make us a better organization. Just wanted to touch briefly on our strategic plan. We actually have a 10-year strategic plan. We felt with the transformation in healthcare that's coming upon us very rapidly, about 3 years ago, we felt that we needed to vision out farther than the typical 3-year strategic planning process that we used in Mountain States to 10 years. What is healthcare going to look like in the United States in 10 years, and how do we position Mountain States Health Alliance to be successful in this transformed healthcare organization? As a result of that, we ended up with 6 strategies. 3 of these are what we call core strategies, and then 3 are supporting strategies in support of achievement of those core strategies. The first one is very much about changing the model of healthcare from the fee-for-service episodic sick care model that we've had for many years in this country to one that truly is focused on population health management, identifying those segments of the population and what we need to do to keep them as healthy and well as possible, and taking them out of high-cost settings like hospitals and emergency departments. Recognizing that, that trend is moving that way fairly rapidly, we projected over the next 10 years, over that 10-year period, that we would lose about 30% of our inpatient volume in Mountain States, absent taking market share from our major competitor. Well, if we do that, that takes a lot of revenue out of our organization. How do we backfill that lost revenue? The first strategy helps us get there to some extent through population health management and entering into shared savings models with insurers, plus having our own insurance company where we can get the full benefit of effectively managing the health of populations. We can backfill part of that lost revenue. We've already demonstrated that. We were among the very first ACOs in the country, and definitely among the first in Tennessee and the first in our region. We've been in, and this was July 1st a year ago, we've been in this a little over a year now, and we had 14,000 Medicare recipients that were attributed to us for the MSSP program. After the first year using the government's template on this, it looks like we saved $10 million to those 14,000 Medicare recipients, of which we get 50% of that back, or $5 million. We also have our own Medicare Advantage plan. We're now in the second year of enrollment for that. It looks like we're going to approach somewhere around 2,000 enrollees in our plan. So again, it provides us an opportunity to effectively manage another population out there of Medicare patients. Then likewise, where we started with this was with our own team members and their dependents, about 15,000 enrollees there. And year 2 of this, we've saved our system over $500,000 through effective population health management. Second core strategy relates again to how do we backfill lost revenue on the inpatient side. Well, it's continue to grow and develop the other components of that continuum of care, which are going to become increasingly important in population health management. That's the ambulatory, outpatient, and retail side of the equation. We've already got quite a bit of things going on there now, but we're going to have a lot more in the future, again, in terms of generating additional revenue. Strategy 3 recognizes no matter how well we do on strategies 1 and 2, we're not going to be able to backfill all that lost revenue from lost inpatient activity. Therefore, we're going to have to really take the waste out of our processes. If you look at our comparative cost data compared to others around the country, and we're a part of Premier, so we have a very effective way of doing that, we're in the top decile performance and have been for some period of time. That's not going to be good enough for us, and we've recognized that. And in Strategy 3, we really decided that the tool for performance excellence and taking waste out that we're going to use is lean. We've contracted with Simpler, a consulting firm that's been in this business for 40-some years in all aspects of business and industry, as well as the military, to work with us. And the first year and a half that we've had them involved in this with our organization, it appears in terms of the return on investment, solid numbers, that we've saved or added additional revenue of about $23 million in terms of bottom line effect for our organization. So that's strategies 1, 2, and 3. I'm not really going to spend any time on 4, 5, and 6, but these are things that really help support the achievement of the first 3. And with that, I'm going to turn it now over to Pat.
Thank you, sir. I'll just back up one. Well, we're very excited, as you've seen with the introduction from Dennis, of talking a little bit about then how do we work with our leadership. And we've heard a lot about that today, that as we onboard staff and we onboard our leadership, the ability to be consistent with that really will, in fact, affect our outcomes. So for us, with a workforce totaling over 17,000 across 2 states, it's really been imperative that we begin to develop those leaders in a consistent fashion. And the goals really include providing competency-based training and development to support our strategic initiative to leverage those strengths across our organization to achieve our mission of bringing loving care to healthcare and to assist the community in attaining its highest level of care. To be able to do that, we focus on 8 leadership competencies, starting with leadership, influencing, all the way to developing people and continuous growth. And we utilize 6 different delivery mechanisms in providing those programs to our staff. And I'll go over those different mechanisms with you. And then we come down to 2 outcomes. And our outcomes really focus on leadership effectiveness and organizational success. And that really gets to the ability to measure our return on investment. We have a leadership advisory committee that I'm involved with. We have an executive coach that we have hired for our organization, someone that had been with the organization many years and has gradually developed to that level. We're very excited about that. And then our executives and physicians are also part of this governing structure. So if you look at us, we're developing leaders across the organization. We start with what we call our aspiring leaders. So any one of our staff that's interested in having some additional skills are able to take individual courses. If we look at that, we have what we call TMAGs, team member engagement groups that work within all of our facilities, and these are frontline staff. So if they want to learn how they can more effectively hold meetings, do agendas, we have courses that are available with that piece of it. Then we talk about our novice to mid-level leaders that are onboarded, our managers and directors, all the way to our executives. For our new leader onboarding or orientation, we work around a 30-day, 60-day, and then 90 to 180 days. And as part of this, one of the things that you heard Dennis say is we're a lean organization. When you see the term VOS, we've decided we have actually titled that value optimization. So we didn't focus so much on the lean, which is really taking waste out, but we didn't want the staff and our leaders to perceive that that meant we were focused on removing staff, though it does look at reorganization of work. And our Aspiring Leader program, as we've said, goes through all of the different levels looking at the target audience, enrollment, and expected outcomes. With this, you can take one class, or within a period of 6 months, if you take 6 classes, you can actually receive a certification. And then these prepares the frontline staff to actually enter into leadership positions. And I think we, like all organizations, especially a healthcare organization, had very typically promoted people that might have been, for instance, a very good nurse, a very good therapist, and not necessarily were they the best person to be the most effective leader. And then what we have after the onboarding piece is what we call leadership development. So we go through the traditional onboarding, and then we put our leaders into a 12-month program where we develop them over time. Because one of the other mistakes you tend to make is you bring somebody in, you sort of put them, as we did historically, into a 2-day program, and you believe they're going to retain all of the information and be able to effectively manage and lead. And we all know that that is not feasible. The other thing we've developed is what we call our own fellowship program. We have started with the senior executive coach to do more internal programs versus all of the outsourcing. We still do, like with the advisory board, our senior executives, but we've now developed a fellowship program. These programs that we develop are in line with our VOS or our lean initiatives, and that means that we work effectively with our directors and actually have outcomes of those programs in the organizations. So as we're onboarding our own new staff now, then we have consistency through leadership looking at those competencies over time. We have a mentoring program. We've done mentoring programs in the past. We have mentoring for our executives, but we've started a new mentoring where we have 8 pairs of people. You can choose to be a mentee or a mentor. We give people choices. Many of them move through different people because of various different learnings that they have. The only thing that we ask is that it's agreeable between the two of those. And we really believe the focus of that is to really improve retention and our bench strength. We have a very effective preceptor program. In our organization, we have about 900 preceptors. And our preceptors, you know, historically, we all tend to focus on our more senior staff. And you kind of burn those staff out over time. So we found as we've onboarded our new staff members, they actually work much more effectively in the first piece of coming in with a newer staff. So even someone that's been there 6 months to a year can go through a preceptor training. We do a training program for them. You can see we look at the satisfaction of that program. We look at the increase in learning, and that gets you to begin to look at your level 1s, your level 2, and then we can actually look at a competency validation of whether those that are going to precept the new staff that we're onboarding, in fact, have demonstrated the competencies from the program to be able to do that. Higher education, we partner with our universities, our community colleges. We do that across the board. We've done that for many of our clinical programs. We do that for leadership programs, our business programs, and most recently around our IS programs, so that even if we have our new graduates coming out, they're cognizant of the systems that we're using and have a much better transition into the organization. The previous group had talked a little bit about independent development plans. We have an independent development plan for every manager and every director. And that really goes into a 360, but we're fortunate to have tools. We use a Profiles PXT, which is a tool that we use to actually employ staff in addition to a DISC profile. We do those, and then we have the staff rate themselves and their one-up manager rates them. And then based on this information, they develop the plan, they touch base with that quarterly, and then that feeds into our yearly cycle of their performance improvement. For our executives, we have recently established a program for all executives, in addition to the traditional onboarding. We use Crucial Conversations, which is a Vital Smart program, but we have staff that have actually been trained to offer that, so we're able to offer it within our own organization. We're doing some ACHE training so that you can receive the credits for our executives on site. We just did one of those last week. And then we do our value optimization certification. So they actually get a green level certification, which is offered through the University of Wisconsin with Simpler. We focus on pace setting, leadership styles, and presentation training. And we also work with the HAY organization with our executives. So when we get that feedback back and we look across the 6 different leadership styles, and we want all of our executives to have a combination of those styles, because depending upon what's happening, it's imperative that you can move between those. Each of our executives is linked into our senior executive coach, and then they work with their direct supervisor, and we do quarterly updates to look at where they are around the continuum of their action plans. With our leadership forum processes, we've gotten our leadership forums. We have 500 people, and for the first time this last year, we've focused on outcomes. So it's not just about we're coming together to learn, but we're coming together to have outcomes. And we focused that around our VOS initiatives. So we haven't just started in some facilities, but we've taken that across. So if you look at what our outcomes are, you can see that our satisfactions have improved. Our internal promotion rate has increased from 22 to 27%. The ASHRA rate is 9%. 24 of our participants in the Advanced Advisory Board have been promoted or have accepted expanded responsibilities. And then we focus on team member engagement and retention. We use Moorhead, which is now linked in with Prescani, to look at team member engagement. This specifically looked at the feel of our team, a feeling that I have the training I need to do a good job. We increased in that, but we want to focus on being top decile. And then as we look across our programs, you can see we measure increase in knowledge. We also look at those in terms of leadership development that are promoted in that particular area. And then for our forums, we had, it was really empowering our leaders to just do it. Because many times it's like, well, we need a new policy, we need this permission. It was just do it. You're able to do it. And at the end of that, and we tracked this, they had to turn in what they were going to do. There were 700 actions that were taken to bring a greater value. And if you say, well, what kinds of things are you talking about? Is that just clinical? Well, we actually looked at our EAP program where we could increase volume. One was in admitting to decrease registration time, home health to have a 35% increase in supply charge capture. And then we go and cost out what are the cost savings of those. But that was a really eye-opening piece to the executives. For our physicians, you can see that if you look at the, we actually established leadership or physician onboarding programs in addition to our leadership programs. And we have an achievement of 4.5 on Likert scale as compared to the advisory board. And then our successes, what do we celebrate? Our participation in our leadership offerings have gone from 40 to over 2,000. So huge success in the organization of that. In working, we're fortunate to have the tools. In working with our local schools and through a grant, we were actually able to offer training for about 1,500 of our team members on Microsoft training. And for many of us that we think we really know a lot, when they did an assessment of us, we really didn't know as much as we thought we did. And the other thing we've done that we just finished with ACHE was to offer 6 hours of credit on site, and that helps us with costs. We celebrate 58 of our team members were just recognized for completing our leadership development series. Our Physician Leadership Academy was a 2-year program in conjunction with ACPE, and actually the president was available for the commencement exercise for the physicians. We really started to link into social media. We have now an intern, what we call No Network, knowledge needed for your development. And we're doing a little piece around Facebook, which is pretty limited to us with our nurse residency. And then we've established an external app that you can see in the lower right-hand corner to allow our community to come in and participate in our leadership programs and quality programs with us. I think I'm right on time.
Such a great job. Thank you.